everyone.
And
All right,
yes,
welcome.
well, welcome. I'll introduce Dr. Rebia Khan in a moment. Thank you so much. Welcome to the Navigating Hospital Stays with Parkinson's. Dr. Khan had actually asked us if she could present on this topic, and we thought, wow, this is such an important topic, which I'm sure you're familiar with. So Dr. Khan will be talking about when to go to the hospital, what to expect, and I'd like to introduce this wonderful third-year neurology resident at the University of Pittsburgh Medical Center, Dr. Rebia Khan. She earned her undergraduate degree from Stanford University, and then she completed both her master's in public health and her medical degree from the University of Arizona. And Dr. Khan plans to apply both her clinical and background in public health to advance the care of those living with Parkinson's. Thank you everyone for joining, especially Dr. Khan for providing this important talk. And please take it away.
Hi, everyone. Thank you all for coming. I'm going to go ahead and share my slides here um, and get started. That on presenter mode. All right. So we're going to get started. This is a presentation on Parkinson's disease and hospital stays. This was a topic that I thought was really important. Most of my residency training is in the hospital and in inpatient setting. So I thought it was really important to address kind of some of the challenges that I see with Parkinson's patients in the hospital, kind of the challenges that they and their loved ones go through, and kind of how we can work together to make this a better experience. Going to the hospital is not fun for anyone. And I just wanted to have a presentation about kind of what to expect so that some of these things aren't so overwhelming if you or your loved one need to go to the hospital. One of my kind of caveats is that I'm not anyone here's Parkinson's doctor. And so a lot of this will be very general, kind of general advice that I have, and none of it is specific medical advice to anyone's situation. And if you do have questions about that, the best person to ask is your Parkinson's doctor. So let's get started. And I think Casey already mentioned, but there will be plenty of time for questions at the end. So if you have questions, put them in the chat or jot them down, and we'll kind of circle back at the end. All right. So starting with kind of what we're going to go over in this presentation, when to go to the hospital, what kinds of things to bring with you, what to expect, what happens after the hospital stay, and then circling back to what about elective procedures where you have a little bit more time to plan what will be going on. Starting with when to go to the hospital. So this can be really tough as a caregiver or loved one to make a decision on whether this is something that you should talk to your loved one's neurologist about or primary care doctor, or whether this is something that needs immediate medical attention. So the things that I like to remember are Parkinson's symptoms should be gradual, and things that are gradual and within the realm of what you've seen before, it may be okay to talk to your neurologist first before going straight to the emergency room. So things like a gradual increase in the symptoms that you have already had. If your medications are not working quite as well as you want them to, like they're wearing off, or you're having some side effects that are bothersome but not life-threatening. So again, non-emergency symptoms are things that are gradual onset, not interfering with breathing or how your loved one is talking to you, and that you feel comfortable that can be continued to be cared for at home. As opposed to that, when should you seek immediate medical attention? And the key word here is sudden changes. So any sudden severe changes in symptoms are things that you should consider whether you need to get immediate medical attention for. So if your loved one is talking to you one day, able to walk okay, and then suddenly has a change in their mental status where they're not responding or talking differently, that's something where you need to think about seeking medical attention. You may have a loved one who has frequent falls, but falls with any sort of head injury, striking their head, anything where their level of consciousness has changed after, they're not talking to you as much, or any severe pain where you're concerned whether they have an injury or a fracture. Any severe reactions to medication. So, if you're starting a new medication and you have a new rash, difficulty breathing, worried about an anaphylactic reaction, that should go to the emergency room. And again, any swallowing or breathing problems, that's really important. The last one I'll say is stroke-like symptoms. And again, these are sudden, severe symptoms. And so things to look for are if, they're talking to you one day and the next day it's hard to get the words out. Any sort of one-sided symptoms, so strokes usually appear as one side is weak while the other isn't, or a facial droop, or they're slurring their words when they weren't before. Those are things to look out for and think of, is this a stroke? And do I need to have immediate medical attention for my loved one for this? It's important to know as well that if you call EMS, they can come check out your loved one and make a decision of whether they need to go to the hospital or not. And they may say, this is a case where we don't think that you need to go to the hospital, and that's okay. It's okay to have them checked out if you're nervous about it. Anything where you feel like you can't take care of it at home, or if you try to reach your neurologist or PCP and you haven't heard a response yet and things are getting worse and it's making you nervous, it's time to go to the hospital. If you're in the case of having to go to the emergency room or go to the hospital, there are certain things that I would say are really important to bring with you to increase the chances of success here. The biggest thing is bringing your medications from home, the actual like pharmacy bottles, so that your doctors can see what medications you're currently taking. Um, and then beyond that, even in having a medication list with that is important. And this is why, with the carbidopa levodopa, as you know, it's really important to have that the doses and times be exactly how you take it at home. And that might mean that you have kind of perfected your home regimen where you take it at 8 a.m. and then 10 a.m. And we don't want a situation where that information is lost when you're in the hospital. So, having a list of when you take your medications and at what time allows your care team to be able to order those the exact same way when you're in the hospital. If you have a DVS device, I would advise bringing the remote and device card and anything that comes with it. Just because if they need to interrogate the device, it'll all be there and won't cause any delays. Other helpful things to bring to the hospital are a list of medical conditions. This helps us know, if we're starting a new medication for you, what kind of interactions we should be looking for, what things that we should be following while you're in the hospital. Um, a contact list is also a great thing to bring, especially who you want any care team members to call if there's any decisions to be made or anyone that you absolutely want updated. If you have an advance directive, a post, or even just a code status that that is something to write down and bring with you because we will need to have that information when you're in the hospital. I want to make a plug here for the Parkinson's Foundation in Western Pennsylvania because they actually have medical safety forms on their website that you can print out and fill out with your Parkinson's doctor. And it includes like a physician letter that you can show to your care team in the hospital, DBS form, DUOPA form, RITERI forms. So the more information that you have about about your care and your medications, the better. And I feel like these are really great resources. Moving on to what to expect when you are in the hospital. So kind of going through the normal flow of a hospitalization, usually start in the emergency room, where they'll kind of triage your symptoms, try to figure out what's going on, and handle any emergency conditions. After that, you may be recommended to be admitted to the hospital and you will be moved to an inpatient floor. After that, you may be recommended to go home and follow up with your outpatient doctors, or they may say you may benefit from going to a rehab for a little bit to get stronger before you go home. And we'll kind of walk through each of these. So, in the emergency department, they're going to triage your symptoms. They'll order basic labs, basic studies like x rays and imaging that can be done quickly. They're looking for possible causes of your new symptoms. The important thing to note is you may come in with neurological symptoms or symptoms related to your Parkinson's, and they may do kind of a full workup to see if there's anything else that might be going on that's making things worse, like an infection or changes in your electrolytes. So if you see them getting labs and things like that, it's usually so that we have a full picture of what might be going on. Then, if further diagnostics or treatments are needed, and they think this is an issue that you need to stay in the hospital and be monitored closely for, they'll recommend admission to an inpatient floor. The important thing about this is even if you are a neuro patient, meaning you have a neurological condition, you may not be on a neurological floor. It actually depends on what the symptoms and the main thing that you're coming into the hospital today for is. So you may be admitted to a medicine floor or a surgical floor. And then if those doctors need some neurological input, they can always consult the neurology service in the hospital, and we'll talk more about that. Um, they may evaluate you in the ED and say, hey, you actually can, like, we have done the necessary tests here. We have, an oral medication that you can take at home and follow up with your primary care or your neurologist. You don't need to be admitted today for this particular issue, and we feel like you're safe to go home. Um, this is not them being rude or saying like, your problem isn't serious. And it's important to note there's a lot of challenges and risks, frankly, that come with the hospital. There's a lot of germs here. And so we want to avoid any hospitalization that's not necessary. And so if they recommend that you go back home and continue getting better, you can always call your neurologist's office the next day or your primary care doctor to kind of check in with those symptoms as well. If you're admitted to the hospital, we'll kind of go over a few things to remember and expect. One of them is that your doctors will round daily, and usually this will be very early in the morning. Especially if you're at a teaching hospital, there might be multiple trainees that see you in the morning. We will unfortunately wake you up at like 6, 7 a.m. in the morning, ask you how you're doing, do an exam, try to get things in order for the day. Um, we hate to wake you up in the morning. This is unfortunately something that we have to do so that we can see all of our patients as early as possible and get things rolling as far as your care. We don't want you to be sitting in the hospital waiting for things to get done. So we try to get things, see you as early as possible so that we can address all your needs throughout the day. Beyond us as your care team, you will be getting labs in the morning and frequent vitals, meaning your blood pressure, your heart rate. These things will be checked early in the morning and then throughout the day because we want to keep a really close eye on that while you're in the hospital. And as you're admitted, they'll continue diagnostics. They may do more imaging. You may be continuing treatment like IV antibiotics we can do on the floor and kind of monitoring your response. Some things that are different in the hospital that I wanted you to be aware of is sometimes people come into the hospital and have changes in their ability to swallow. We see this a lot with people who have strokes. And so we may say, hey, right now, you're not safe to swallow on your own. And your care team might recommend having a duo tube, which is a tube that goes from your nose to your stomach or a little bit past your stomach to be able to get nutrition and medications. I just say this to kind of reassure that this can be a very temporary thing. It can be just while you're in the hospital, and as your swallowing gets better, this is something that they can remove before you go home. And then you're making, again, with this and everything else, you're making a long-term plan with your doctors about how you're going to move forward. And physical therapy, occupational therapy, and speech therapy can see you in the hospital, and they usually do. An important thing to remember is that it's not a full physical therapy session that they're doing with you every day. This is really more of an evaluation than a therapy. They're trying to see how you're doing compared to your functional status at home. So they're trying to figure out, hey, are you someone that could benefit from some rehab after this, or are you someone um, that can go straight home after this hospitalization? So, some questions that we frequently get: how do you get your home medications while you're in the hospital? So, I told you you should be bringing in, if possible, that, like, a bag of your medications in the pharmacy bottles with a label on them. Unfortunately, you actually can't take those medications while you're in the hospital. We will go through those medications with you and put them into the computer and order them so that you get them from the hospital pharmacy at the time that you get them during the day. And that's based off of hospital regulations. And then what if your medication is not available in the pharmacy? So if you're on a certain brand of medication or something that's harder to come by, it's very possible that our pharmacy won't have it. And in that case, that is the only case where you would use your home medication. And the way that this is usually done is that the pharmacy will you will give your medication to the pharmacy. They'll examine it and then give it back to your nurse, and your nurse will give it to you at the times that it's ordered. And that brings us to some of the challenges that I see with for patients in the hospital and kind of how to address them. So, one of the biggest challenges and kind of sources of anxiety in the hospital is medications not given on time. And so, we all know that with your carbidopa, levodopa, it's really important that you stick to your schedule and take it when you need it at exactly those times. Unfortunately, with hospital regulations, they can give it to you an hour before or an hour after, like an hour window either way. So, for example, if you usually take your carbidopa levodopa at 8 a.m., anywhere from 7 to 9 a.m. is when they can give it to you and still be like within the regulations. And that's kind of above all of us as far as how those regulations are made. Um, the things that I would say help set you up for success are: one, what I mentioned before, bringing that medication list and writing exactly when you take that medication and what dose you take at that time. That ensures that your care team can order it the exact same way and let your nurse know that that's how you need to take it. Um, and then again, bringing in those medications that might not be on formulary, so there's no delay in getting those either. And lastly, it is important to advocate for yourself and or your loved one. And this is unfortunate that we have to do this, but I think it actually really helps if you talk to your nurse and tell them, if I don't get this medication at around 8 a.m., I get really wiggly, or it's really hard for me to talk or walk, and it's really important that I get it on time. And when everyone kind of has that understanding of why it's so important that you get it right in that window, there's more chance that everyone will be able to do that. Another challenge is medications not working like they usually do. So even if you're getting your medications exactly how they're dosed at home, um, you're getting them right on time in the hospital, you may notice that you may be more wiggly than usual, or you may have more off time than usual. And this is because, and we do see this pretty often. when you're in the hospital, you may be sick with an infection or something else might be going on. So any changes in your health condition, you're eating differently than you usually do, your activity level is a little bit different when you're in the hospital, can kind of change the response that you have to your dopamine medications. Um, and that's something that we actually expect while you're in the hospital. And for that reason, we usually don't make major changes to your carbidopa levodopa while you're in the hospital because we know that things are going to be a little bit out of whack while you're here. And it's usually better if your neurologist makes those in your home environment so that it's titrated to where you'll be for most of the time. And then this is one of the most important topics, hospital-acquired delirium. This is really important because it's very sudden and it kind of catches families and patients really off guard, but it is also really common. So, hospital acquired delirium is a temporary confusion while you're in the hospital that can lead you to forget where you are, what's going on, what time of the year it is. Um, Not recognize your care team or even your family members. And that can cause a lot of anxiety and even anger and agitation. And you may see your loved one acting very differently than they usually do. And that can be really scary. This is something that we see quite often with elderly patients, and people with Parkinson's disease are even more at risk. The things that we try to do to minimize this risk is really just kind of trying to keep the routine as much as possible. So your body needs to know when is awake time and when is sleep time and have a really good schedule with that to be able to prevent this from happening. So we like to say awake with lights on during the day, try to keep your brain engaged. So if you're visiting a family member, it's really helpful because then they'll, be talking to you all day. And then by the time it's nighttime, they're tired and want to go to sleep and they sleep well. We also try to keep reorienting, meaning we kind of repeat the same things. I'll say, I'm Dr. Khan, I'm your neurologist. You're in the hospital, you're at Presbyterian, it's November. Just so you kind of keep hearing the same things. So you kind of ground yourself of where you're at. You may see that certain medications are prescribed if those orienting techniques and kind of trying to keep the day-night cycle don't work and the delirium is getting worse. Some of these that we use, especially in Parkinson's patients, are quetiapine and melatonin. The important thing to note about this is that even if you or your loved one are prescribed these in the hospital, that doesn't mean that it's a new medication that you need to take forever. It may be just while you're in the hospital and you don't have that, you're not anchored to your routine, you need these, and then after your discharge, you can stop taking them. And lastly, new doctors. So, the way that healthcare works like in the current setting is usually the doctors that see you in clinic are usually not the same doctors that you will see in the hospital. So within the hospital, there's hospitalists and a neurology consult service, and that consult service may not be your Parkinson's doctor from clinic. Um, so that's why it's so important to bring as much paperwork as you can, as far as your medication lists and your health conditions. If you are in the hospital of the same system as your outpatient clinic, we probably will be able to see your notes from your outpatient doctor, but there are times that we can't. So we kind of rely on those other factors to get that information. The other thing is your Parkinson's doctor might not be able to make recommendations while you're in the hospital. If your Parkinson's doctor has previously said, hey, if you're ever admitted to the hospital, you can have your care team call me if they need help. That's really wonderful of them. You would have to have your team reach out to them. So it has to be in that direction. Your Parkinson's doctor can't make a call until they ask for that help because we don't want to be stepping on toes. And so that's something that you can ask your team while you're in the hospital if you feel like they could use some help with your specific Parkinson's medications or anything else to do with your Parkinson's. Then moving on to what happens after your hospitalization. So, on the topic of discharge, so while you're in the hospital, inpatient physical therapy, occupational therapy will work with you to determine your discharge needs. Like I said, they take into consideration your home environment, like do you have stairs that you need to get up to, who's at home with you, and they may say, you're looking great, you can go directly home, and we think that you'll be safe there. They may say, "Hey, you have a little bit of weakness from either this condition, what happened during the hospitalization, and you should probably have some time in rehabilitation before you go home just to get you a bit stronger." There's two main types of post-discharge rehabilitation that you may have heard of. So one is a skilled nursing facility, and one is intensive inpatient rehab. We'll start with intensive inpatient rehab. It's exactly what it sounds like. It's a full day of rehab activity, so physical therapy, occupational therapy, and it's over 3 hours a day, but it's actually even more than that. It's throughout the entire day. And this may be temporarily for like 2 to 3 weeks. This is really for that like intensive therapy to kind of cover really big ground in a short amount of time. Um, and not every patient is kind of up for that because you need to be able to tolerate doing activity and doing physical therapy for multiple hours per day. And so physical therapy may say, you know what, you still need therapy, but I don't think you're someone who's going to be able to do therapy all the time for 3 weeks straight. And so they may recommend a skilled nursing facility. So these facilities will help you get your medication on time, take care of your needs, and then they have physical therapy come to the facility to be able to still get that physical therapy, but it'll be less than 3 hours per day. Ultimately, this is a decision with you and your care team and your family to figure out what is best for you. Some of these things can be really out of our hands as your doctors. So, if you are not recommended for intensive inpatient rehab, there's limited things that we can do as far as your care team to kind of get you there. Because really, we want you to be where you're going to succeed. And if you're not able to tolerate that high intensity rehab for a full 6 hours per day, that's maybe not the best place for your loved one to be. We want to set you up for success there. And then what do you do when you return home? So, big things for post hospitalization are one, follow up, and two, medications. So, when you get your kind of discharge paperwork, it will tell you, hey, you should follow up with these certain specialists and your PCP. Um, Make sure you note that because that's really important for each doctor to kind of see you and follow up on things that happen in the hospital, make medication changes, make sure that you're doing okay. Um, bring any paperwork from the hospitalization that you have that helps when you go to your outpatient appointments. And then the other thing to note is sometimes it'll say follow up with your PCP or your neurologist within 1 week. And you may call your neurologist's office and find out they are booked for 2 months. Um, it's important to note here that this can also just be a check-in, so you can call your neurology clinic and say, "I was hospitalized for this. These are, like, the things that happened. When should I see you next?" And they may say, "You know what? If you're doing okay, we can keep the appointment that you have on the books," or they may say, "Let's try to get you an earlier appointment to follow up on some of these things." So that 1 week can actually just be you making the appointment or making a plan. Um, and then medications. So take note of your new medication list, which will be one of the first things on your discharge paperwork. This is really important because medication changes are very common after hospitalization. And sometimes a lot has happened throughout the hospitalization, and it's really hard to keep track of all the medication changes that were made. Your doctors might have you add a new medication. And they may say, you need to hold this certain medication temporarily until this date or until you see your PCP. And those are the things to kind of keep track of. If you have a pill box, make sure that you make those changes because we want to set you up for success after hospitalization. And then kind of circling back to elective procedures. So, a question that often comes up is like, I have Parkinson's disease and I'm recommended to have my knee replaced. Is it okay for me to go through anesthesia and everything like that um, to kind of get this procedure done? And with any sort of procedure, especially with someone with Parkinson's, there's a few different considerations. But ultimately, it's a discussion to have with your Parkinson's doctor. The general kind of view that we usually have on the situation is if it's something where it's a procedure that we can do safely and will help you be healthier and more active afterwards, it's something that we're willing to kind of go through the needed preparation for. So for example, your surgeon might say, hey, you need to meet with your neurologist to get, pre-procedure clearance, make sure that we have your medications in line. Um, and any changes that need to happen from that perspective prior to the procedure. And so you can meet with your neurologist and they'll write a note that your surgeon can see and kind of make those changes. You probably will also meet with the anesthesiologist. And they'll kind of help you understand what medications you can continue, what medications you need to hold for a certain amount of time. And that's something that you can work with your neurologist as well to make sure is okay. For most procedures, since you're gonna have anesthesia, you're gonna have a certain point where you have to stop eating, prior to the procedure, and they may have you hold some of your medications at night too. We usually say it's okay to kind of have that, last point where you can eat, take your last medication, and then it's okay to hold your medications the next day. But each one is kind of specific to the medication, and that's why it's so important to have that pre-procedure appointment with your neurologist to go over that and anesthesia as well. So procedures usually require anesthesia. Your anesthesiologist will kind of go through the risks and what they need to consider as far as your anesthesia risks. And then during the procedure, something that's important to know is if you have a DBS, they actually can call your representative of that company to help out during the procedure if anything changes and they need to know, like, can we change the settings or are we okay to go in on this spot? That's something that they have that resource for, and you can give that to them ahead of time, making sure that they know what company your DBS is with, and again, bringing all that DBS the card and the remote. And then after most procedures, you'll probably stay in the hospital at least one night. Again, expect delirium. It happens. You're going to be going through anesthesia, kind of recovering from that, recovering from a procedure, and that's a lot of stress on your brain. And so, what we tell patients is you can warn your family. Don't take anything that I say after the procedure seriously. I might act different. And then don't make huge decisions right after your surgery. So don't be buying a car the next day. Let yourself recover. Um, and then again, recovery might look like physical therapy and might be kind of extended. But in the end, if it helps your level of function and helps you keep you active and healthy, that's ultimately what we want. But again, can always talk to your neurologist about that. And then I want to end on some very helpful resources that are online. One is the National Parkinson's Foundation has a hospital safety guide. It's a really long, like 60-page document. You don't need to read all of it, but the first few pages actually have a checklist of things to bring with you if you go to the hospital in like a very easy format. And then again, the medical safety forms that we mentioned on the Parkinson's Foundation of Western Pennsylvania website. I look through them and I think they would be very helpful for your inpatient team. There's one, like there's a physician letter that you can go through with your neurologist to make sure that they include the things that are important when you're in the hospital. So I think those are great resources to check out. And then I will open it up for questions.
Thank you, Dr. Khan. There are quite a few in the chat.
Perfect. Let me just stop sharing and take a look. Casey, did you want to read them and I can?
Yes, I will. Christine mentioned about the forms, and there's a link to the medical forms on our website. Thank you. Right in the chat. And how important is it to stay on your current meds while in the, I think that means hospital, like Rytari, but they only carry Cinemet. What if the hospital does not allow you to bring in your own meds?
That's a great question. So there is, you know, when you're in the hospital, if they aren't able to have your home med, um, they may say you can bring it into the hospital and do the kind of non-formulary situation that we talked about, where the pharmacy looks at, like for example, your Rytary and is able for you to get it through our medical medication system. And then there may be a chance that they would actually substitute that medication. So, in that case where you're not able to kind of bring in your home med, there is a chance that they would substitute it. That they would work with the pharmacist to make sure that you're kind of getting the same amount that you would get in the same kind of effect. And again, there may be small changes because it's not exactly what you get at home. And then as far as not allowing you to bring in your own meds, usually they do allow you to bring in your meds, but they'll kind of keep them in a different place while you're in the hospital and kind of give them back to you at the end of the hospitalization. That's kind of what I've seen for most hospitals. It's less about them completely not allowing you to bring the pills in to the hospitalization, if that makes sense.
Thanks. And what's the best way to make sure your medications don't, or make sure you don't get contraindicated medications?
Yeah, so the nice thing in the hospital, especially like bigger hospitals like Presby, is that there's a huge pharmacy department and there's a few different checks on your medication. So your physician will look through your medication and your medical conditions, and before they prescribe a medication, will look for any contraindications to that medication. So that's kind of the first check. And then they'll order it on the computer. And if there's already a drug interaction where that new medication doesn't, you should not take it at the same time as one of your other medications, that is already in the computer system and they'll be alerted to that. So that's kind of the second check. And then a third check is that a pharmacist will review that order. So someone who is trained in pharmacy will look at your medication list, your medical conditions, and look at that particular medication and make sure that it's safe for you to take. And so between those different checks, we try to limit giving you any medications that are contraindicated. The other kind of last check is if you are someone who knows that you have an allergy to a medication, or you know that your doctor has told you this is contraindicated, that's something to talk to your doctor about to make sure that they know too.
Thank you. Would you say that that's the same method for maybe smaller community hospitals as well?
Yeah, so most hospitals have at least, your doctor's looking over your medication list and a pharmacist in the hospital before they dispense it.
Thank you. And what if your doctor doesn't come to the hospital? Who would you see instead?
Right. So in the healthcare system, so there's your outpatient doctor who you see at clinical appointments, and then there's certain doctors who only work in the hospital. So they're all range of specialties. Like you can have general medicine doctors that just work in the hospital, and there's neurologists who just work in the hospital. And so it would be a local neurologist who is running the consult service in your hospital, meaning that they take any consults for any neurological question in that hospital. And they'll see you and they'll talk to you. They'll kind of review your records, go through your history, and then they'll make recommendations for your care team in the hospital, and help them with whatever the neurological concern is.
Thank you. Okay, another question. If a duo is required, how does a patient take their carbidopa levodopa pills?
So with a duo, you can take carbidopa and levodopa pills through it. For most medications that you can crush, you can take them through the duo tube. There are some changes, like I mentioned, with if you're getting, for example, tube feeding through the tube, the interaction with the protein in the tube feeds or what you're currently eating may change how the effect is for your body during that time. So again, that's another reason why your carbidopa and levodopa might work differently when you're in the hospital versus not, is kind of those changes in what you're consuming. Um, but that's again something that we would expect.
Thank you. Another question. Why don't the nurses know the importance of timely treatment for Parkinson's patients?
Yeah, so it's a really big challenge, and I would say like all the nurses that I've worked with, wonderful. They're trying their absolute best to make sure everyone gets what they need. Um, Sometimes they have multiple patients that have different needs or emergencies that happen, and unfortunately just cannot get you that medication in time. But I would say most of the staff, especially if you're in a neurological unit, know the importance of that. It's all the constraints of the hospital and the challenges of the hospital, unfortunately.
And moving on to another topic, another question. How does delirium differ from Parkinson's disease psychosis?
That's a good question, and it's kind of like how I think of it is kind of a spectrum. So, delirium while you're in the hospital, or what we call hospital-acquired delirium, is something that Parkinson's patients can and are more at risk for, can have and are at more risk for. But we kind of see that as a triggered event that happened because of being in the hospital and being in this certain situation where you're not in your home environment and you don't have your routine and things are kind of off. Um, so we do see that um, as kind of a temporary, what we expect to be a temporary thing, because you're in a different environment than you usually are, versus a Parkinson's disease psychosis would be more of a primary new disease event, which may mean that you would be on medications for a longer term, versus in a hospital acquired delirium. You may not be treated with medications at all, and if you are, those may be temporary.
And I think you've answered this question, but I will ask it anyway just to confirm. Is it just found with Parkinson's patients, or is that something that can happen for any type of patient?
Yeah, that's a great question. So it can happen to any type of patient. It's it's so common in the hospital. Um, Definitely, if you have an underlying brain condition, you're more at risk for it. But even patients that don't have any neurological conditions can have hospital-acquired delirium.
Thanks for clarifying that. And what if you're out of town, for instance, on a vacation and you need to go into the hospital and you do not have your notes? What are some other options or tips, please?
That is a great question. And I think one of the things that I would say is kind of have some of those things on your phone as well. So with the forms, you can take a picture of those forms to have with you. Your medication list, you can take a picture or have it as a written document in your phone. Um, that is actually such an important point because if you're away from home, especially if you're in a different state, the chances of that hospital system being able to see your notes from your prior hospitalizations or your outpatient clinic prior are even lower. And so, the more information that you can give them about your medical conditions and um, your medications is even more important. The other thing that they can do if they're really at a loss, you like did not bring your medication list, you don't remember exactly what you take, is you can tell them where you get your prescriptions filled and they can call the pharmacy to kind of see what have you filled in the last few months. And then they can kind of go over it with you to see what you're taking currently.
Thanks for those tips. And this is the last question in the chat for the moment. What if I was in an accident and brought into the ER? How does the staff know that I have Parkinson's if I'm unable to communicate that to them?
Yes, and that is definitely a challenge that we see in the hospital. That is a great question. So, if you're brought into the ER and are unable to communicate your medical conditions, they will try their best to, or we will try our best to kind of figure those out from looking in your chart and seeing if we can see any of your other hospitalizations, outpatient notes, anything like that. That's been one of the great things about having an electronic medical record in the last few years is that even if you're not able to communicate, there's usually electronic trail to be able to tell us your major medical conditions. And then the other important thing to note is when you're kind of in that acute setting, there's things that, override or are more important at that time to kinda stabilize, and we have a little bit more time to make sure that we get your other home medications and your, home medical conditions all straightened out as your hospitalization progresses. And so if you're in that situation, unfortunately, um, we will do our best to kind of investigate with the resources that we have. We'll do everything in our power to kind of stabilize what we're seeing. We'll get, lots of labs and testing to be able to have objective evidence of what's going on. And then we will try to call your loved ones. And as you are recovering and are able to communicate better, get more of that medical history to make sure we, as you're getting better, get you back on your home medications.
Thank you for that helpful information. And we can open it up. If you have a question, you can type it in the chat or just unmute yourself and ask it. Just wait another minute or two. That was a very thorough presentation. Anyone have any other questions? Oh, here we go. Are there always neurological hospitalists?
This is another great question. So, most major hospitals have either a neurologist in-house or they have a contract with a neurology service, which means that they'll have something called teleneurology. And so that's true for most of the UPMCs like in the area, as well as the other hospital systems like near the city. So they'll have what they do is they'll have someone review your chart and they might talk to you through a telemedicine kind of structure, or they'll see you in person depending on what the situation is. If you're in a hospital that doesn't have neurology, so that's like some of the much smaller hospitals may not have a neurologist that they're contracted with or neurology in house, They may transfer you to a hospital that does if your condition needs a neurology expertise. And so they will kind of triage what you need at that time. And if your needs are above what they have in that hospital, if you're in a community hospital that doesn't have that, they'll help transfer you to a hospital that does.
You can imagine, Dr. Khan, that many of our patients don't initially see movement disorder specialists, and they get a lot of bad advice from neurologists. So I just want to emphasize that you need that paperwork with you.
Yeah, the more prepared you are, the better. And we understand that sometimes the situation doesn't allow yourself for that, but um, these are the things that I would say are helpful. And thank you so much for having so many resources on your website. I was actually looking through it before this presentation, and I was like, this is really good stuff for everyone.
Thanks. We try our best.
Mhm.
And another question came in, Dr. Khan. Do the UPMC and the Allegheny Health Network electronic health records talk to each other?
Yeah, so with our most recent EMR, we're able to see some notes from, so as a UPMC provider, I can see some notes from Allegheny EHR, but I don't see everything. And so there may be gaps in like being able to act like, so if you got an MRI at Allegheny, I can see the report, but I might not be able to see the images. And so the communication between those health systems has improved a lot, but it's not 100%.
Thanks again. Any last questions that came to mind for anyone?
We sure hope you stay in Pittsburgh. This was a wonderful presentation.
Yes, it really was. I couldn't agree more.
Thank you everyone for coming.
You're welcome. And I know that there will be other viewers on our YouTube channel, many, and we hope to see you again. Oh, okay. And we might have one other quick question. Do you have one more moment, Dr. Khan?
Yeah.
Okay. Does insurance coverage limit, whoops. Oh, I'm sorry. Does insurance coverage impact the medications that you get in the hospital?
That is a really good question, and I actually don't know the answer. So I would direct you to your neurologist or your health insurance to see if that's true. I don't want to speak on like all the health insurances without knowing fully.
Well, thanks again. We'll end on that. Thank you, Dr. Khan, and hope to see you at a future event. And thank you, everyone, for listening.
Thank you,
Bye for
everybody.
now.
Everyone.
Very knowledgeable. Thank you. Thank you. You know
Bye.
your patients. Very good.